This conference will now be recorded.
Well, good evening, everyone, and welcome to the ACRM Stroke ISIG Virtual Happy Hour. We are very excited to have with us today Dr. Leanna Katz, who is adjunct faculty in the Occupational Therapy Department at Boston University. Dr. Katz originally is from Atlanta, Georgia, and she received a Bachelor of Science in Brain Behavior and Cognitive Science at the University of Michigan in 2010. She later received a Master of Science degree in Occupational Therapy and a Doctor of Occupational Therapy degree from Boston University. She's worked at Spalding Rehabilitation Hospital in 2015, and in December 2018, she transitioned to per diem roles at both Spalding and Shriners Hospital for Children. And in 2019, she joined the Boston University Occupational Therapy Department's adjunct faculty. She's very active in ACRM, and we're very happy to have her here to talk about a topic that's very near and dear to my heart, entitled Health Promoting Behaviors that Improve Quality of Life for Individuals Post-Stroke. So thank you, Dr. Katz. I give you the floor.
Thank you. And did you want to go through the ACRM slides?
Sure. Those slides are just there to remind folks to register for ACRM. Coming in the fall. You can go ahead.
Okay. All right. So thank you everyone for being here. Again, my name is Leanna Katz. I'm currently affiliated with Spalding Rehab Hospital and BU, and I'm here to discuss health promoting behaviors that improve quality of life for individuals post-stroke. I do not have any disclosures, financial disclosures, so this is all just from research I've done in the past that is near and dear to my heart as well. And I've also adapted a presentation that was completed at ACRM, that was presented at ACRM last year. All right, so let's talk about objectives. So today's learning objectives, we will first define quality of life and identify factors contributing to quality of life after stroke. We'll also understand the social, emotional, and physical components impacting health outcomes and quality of life for community dwelling stroke survivors. And I say community dwelling stroke survivors because most of the literature that I looked at looks at least 6 to 12 months post-stroke, post-injury, and up to almost 5 years. So they're typically in the community at that point. And you'll learn how to apply a strengths-based approach to support health-promoting behaviors post-stroke. So we'll talk about the theoretical constructs that will inform our interventions. So what is quality of life? The WHO, the World Health Organization, suggests quality of life represents the widest range of human experience, encompassing constructs beyond health, including such areas as material well-being, neighborhood safety, spirituality, and the environment. So that means this comprehensive view of quality of life includes not only physical health, but also psychological health, social relationships, and environmental quality and personal beliefs. I also like another definition that I found in the literature by Patrick and Erickson that emphasizes health-related quality of life, which is the value assigned to duration of life as modified by impairments, functional status, perceptions, and opportunities influenced by disease, injury, treatment, and policy. So when you consider what makes up quality of life, we don't treat quality of life per se, but rather focus on the individual components making up the construct. So what are those individual components making up the construct of quality of life post-stroke? There's emotional distress and depression, activity limitations and functional status, social factors, perception of self-efficacy, other medical factors such as cardiovascular disease or diabetes, which are somewhat common in the stroke population, and aphasia severity and communication limitations. So the literature shows that the perception of one's ability or self-efficacy and other emotional psychological factors are equally as important as physical factors in predicting measured function related to self-reported disability and quality of life among stroke survivors. I also want to note that this Hilary article about aphasia, they suggest stroke health-related quality of life studies need to include people with aphasia, but report on them separately in order to determine the main predictors of their health-related quality of life and to identify what interventions can best address them. So for the purposes of this presentation, I will speak broadly on the stroke population in general, but it is important to note that individuals with aphasia and other communication limitations may have differing experience and may require a modified intervention approach. We'll brush the surface on it, but just note that they may be in a separate category. So I wanted to present some facts from the literature. There's post-stroke depression. I'll put these up so you could read through it. Decrease participation and ability to be independent in ADLs and functional mobility, self-care, self-efficacy, and just overall quality of life, and then education level. So extensive research regarding disability and its association with increased mortality is very relevant for the stroke population. But most of that research, however, focuses on physical dysfunction and not as much on the social and emotional problems stroke survivors experience. So here are some facts taken from the literature. Post-stroke depression is fairly common. A majority of stroke survivors lacked an important or meaningful activity to fill the day and required assistance with at least one ADL or activity of daily living. The most affected domains, as indicated on the stroke-specific quality of life scale, was in work productivity, social roles, personality, energy, and family roles. And lastly, it has been described that there is a direct association among knowledge of stroke, income, and education that impacts adherence to treatment and maintenance of a healthy lifestyle. So we'll keep these in mind as they will help inform our intervention, which we'll discuss later. So what are the active ingredients that are leading to these predictors of quality of life, and how can we fix them? So we need to be able to identify them in order to act on them. So what are those modifiable factors that can be controlled? This is essentially a summary of the literature from the previous slide that will help us find a solution to intervene accordingly, since we do know that higher quality of life is associated with greater independence in daily living and mobility, higher education level, and better socioeconomic level and social support. Conversely, worse quality of life is associated with anxiety, depression, and fatigue. So some of these factors we can adjust. They are modifiable. We can adjust socioeconomic level and status, but we can look at participation and engagement in meaningful occupations. We could look at health education and supporting and promoting participation in social activities. So that's what we want to do for intervention. We want to address those factors that influence quality of life. We will come back to these shortly, but I do want to highlight the 5-point construct, 5 different areas that we're going to focus on. It is of fundamental importance to elaborate specific programs for functional recovery and develop health policies that aim to achieve social inclusion and readaptation to work or other meaningful activities, as well as health promotion strategies that aim to control risk factors for stroke patients. So it is important to understand these risk factors for lower quality of life, things that could impede community reintegration. And this is in fact where most research has focused, but arguably in order to provide effective interventions, it is just as important to understand what sorts of things are protective or associated with better community reintegration and quality of life. So we're going to look at the self-efficacy and building resilience, which are pretty well connected. Before we jump into the intervention, however, I just want to go over the theoretical constructs that inform our interventions. So to start, we have Bandura's social cognitive theory, or I'll refer to it as SCT, which considers the unique way in which individuals acquire and maintain behavior, while also considering the social environment in which individuals perform the behavior. It is important to note that when considering environment, there are most definitely health inequities that exist in various areas. So it is important to consider availability and accessibility of resources, social and cultural norms, and systems in place that can facilitate or impede behavior change when working with clients of different races and backgrounds. And I'm just going to review some important constructs to recall of social cognitive theory for those of you who it may have been a while. There's an idea of reciprocal determinism right here, which is the central concept of SCT. So this refers to the dynamic and reciprocal interaction of person, environment, and behavior. And then you have behavioral factors or behavioral capability, which refers to a person's actual ability to perform a behavior through essential knowledge and skills. So in order to successfully perform a behavior, a person must know what to do and how to do it. So people learn from the consequences of their behavior, which also affects the environment in which they live, which leads me to observational learning. So this asserts that people can witness and observe a behavior conducted by others and then reproduce those actions, which is often exhibited through modeling of behaviors. If individuals see successful demonstration of a behavior, they can also complete the behavior successfully. And there's the idea of reinforcements. So reinforcements refer to the internal or external responses to a person's behavior that affect the likelihood of continuing or discontinuing the behavior. So reinforcements can be self-initiated or in the environment, and reinforcements can be positive or negative. So this is the construct of SCT that most closely ties to the reciprocal relationship between behavior and environment. And there are expectations, which refer to the anticipated consequences of a person's behavior. People anticipate the consequences of their actions before engaging in the behavior, and these anticipated consequences can influence successful completion of the behavior. And so it's important to note, while expectancies derive from previous experience, expectancies focus on the value that is placed on the outcome and are subjective to the individual. So that's really where it's coming into a very person-centered approach, where it has to be a high value for that individual. And lastly, there's self-efficacy, which we went over briefly, but that refers to the level of a person's confidence in his, her, or their ability to successfully perform a behavior. So self-efficacy is unique to SCT and is influenced by a person's specific capabilities and other individual factors, as well as by environmental factors that can act as barriers or facilitators. Another theory I want to introduce is the empowerment theory, which is actually out of the social work literature. So empowerment can be seen as a process where individuals learn to see a closer correspondence between their goals and a sense of how to achieve them, and a relationship between their efforts and life outcomes. So you start from this idea of powerlessness, and you go through this stepwise process through participation. And it's really here where you start to see the empowerment come to life, having and responding to new information and building on inherent strengths and capabilities. So that's what this is really all about, the strengths-based approach. There are a few underlying assumptions that have to be made with this theory, one of which is that individuals are assumed to understand their own needs better than anyone else, and therefore should have the power both to define and act upon them. And all people possess strengths upon which they can build. Empowerment is a lifelong endeavor, which is key to health and wellness and quality of life, because it's also a lifelong endeavor when you're seeking quality of life. And personal knowledge and experience are valid and useful in coping effectively. So similar to SCT is that you're bringing in these previous experiences that will help improve quality of life and help you think more forward. So the empowerment theory promotes health and well-being in the context of this strengths-focused approach related to active participation in an individual's personal health. So we'll emphasize that active participation through our intervention. As rehab professionals, we are very good at identifying deficits and weaknesses that we target for intervention or compensation, but equally important is to be able to identify retained strengths, as these will be the building blocks on which a new life will be built. So let's jump into our initial assessment. I'm an OT, so we use the COPAM a lot in occupational therapy, which stands for Canadian Occupational Performance Measure, which is an important tool to enable personalized healthcare. So the COPAM was developed as a client-centered tool to enable individuals to identify and prioritize everyday issues that restrict or impact their performance in everyday living. So one of the strengths of the measure is its broad focus on performance in all areas of life, including self-care, leisure, and productivity. So you can see the three different areas here. Using an interview format, the client then is able to self-identify specific tasks that are more difficult now, say post-stroke, and then is asked to rate the importance level. So from there, after the entire form is filled out, the client is then asked to rate the top 5 tasks to focus on for the intervention. So the measure serves to identify issues of personal importance to the client and to detect changes in a client's self-perception of performance over time. It is used as an outcome measure. So the COPAM, which initiates the conversation with clients about performance issues in everyday living, provides the basis for setting intervention goals. And I will say it was designed for use by occupational therapists at a cost and with a training manual, but the overall concepts are relevant and important for non-OTs alike, as the principles of rating one's importance of various activities in these given categories may help focus therapeutic intervention and can be administered through an interview. So the next assessment that I want to highlight is the stroke-specific quality of life scale, which I'm sure many are familiar with. It's a 49-item scale, and it uses a 5-point Gutman type scale that goes from total help, couldn't do it at all, strongly agree, to no help needed, no trouble at all, strongly disagree. The scores range from 49 to 245. And higher ranges, a higher score equals better functioning. And you can see there are 12 domains that they cover: energy, family roles, language, mobility, mood, personality, self-care, social roles, thinking, upper extremity function, vision, and work and productivity. So it seems like a lot of domains and a lot of questions, but it's actually fairly quick to administer. It takes about 10-15 minutes to administer. No prior training, anyone can do it, and it also can be answered by proxies, so that is a plus too. So it is pretty accessible and free. So now we're going to dive into our intervention, and we'll go into our first of 5 constructs. So the first one is promoting independence in meaningful activities. So these meaningful activities can be in a social, recreational, or occupational context. I use the term occupational to be all-encompassing of daily activities as well as work-related tasks. So we filled out the COPAM, we've identified some areas of self-care and leisure work that are of vital importance to the client, and now we're ready to intervene. So let's look at social activities. Here are some examples that I've used with clients really to access social gatherings, and this is different than social supports, which we'll get into. It's a separate category where it would be more of a support group format. This is rather like getting back into social activities that that person was doing prior to the stroke. So going to see movies and book clubs and game nights, afternoon tea, there are music classes, knitting circles, you name it, anything that has a club or a social gathering. that would be it. So it's finding ways to access those gatherings that may be difficult for our clients after they've experienced a stroke. One of those that I do want to highlight, a lot of the barriers most of the time is communication. So it's learning to go back into these social groups with limited communication, which could be very challenging. So that's why I differentiate between going to a specific aphasia group or a stroke specific group where everyone has experienced a stroke and has a better understanding of those language or limitations versus reintegrating into social activities. So that's a big focus of the team. And I do want to highlight that all of these interventions are completely interdisciplinary. The next area of promoting independence and meaningful activities would be recreational. So here in Boston, we have a lot of access to adaptive sports through the hospital, through community groups, for any sort of summer, winter activity, which can be really nice. It's not just for people who have had strokes, but it's for people of all abilities. So it's kind of nice to have that. It's social and recreational at the same time. Or even just thinking of any other hobbies that someone has, and accessing those hobbies. So let's say someone really likes to read, then it would be our job to find ways to access that more easily to increase independence, promote independence with adaptations like a book holder. And the last one is occupational. So you have adaptation versus modification. This is a big area of my practice as an OT. And I highlight prioritization, which you get a little bit from the COPAM, but you really don't know what is important to someone until you interview them. It does correlate with caregiver relationships, so that we'll talk about next. But sometimes it's really important for someone to be able to go to the bathroom independently, and they don't really care about being able to brush their teeth or put a shirt on. They just want to be able to pull their pants up and down to go to the bathroom independently, so they don't have to call their caregiver. So it's really this collaborative goal setting, prioritization that we really need to focus on, and it's 100% person-centered. I also want to highlight that all of these intervention strategies are using a strengths-based approach. We're using what that person has and building upon those strengths. And another thing to highlight is that we're also always integrating energy conservation when we're doing any sort of physical activity, so that could be a barrier for participation in social, recreational, or occupational activities. So next we'll talk about social roles and social supports. So there are oftentimes changes in roles. That's pretty common following stroke. So there's either like a role loss or a role reversal. So let's say the primary provider is no longer able to work and provide financially for the family. So then that role is switched to the other husband, wife, partner, whatever it may be. So there's this feeling of sense of purpose to provide in a role. So it's important to consider these new roles of how you can redefine that purpose. So I've added volunteering and mentoring because I've learned from some patients who I've worked with is that finding a way where they feel like they're providing when they're usually the receiver of help, they want to be the provider. There are nice outlets through volunteering and mentoring programs for new stroke patients that people find extremely, extremely meaningful. So at Spalding Rehab Hospital, we have a very large volunteering program, and people come back to the hospital, share their stories, participate in groups, and it's a really meaningful activity. Next, I want to talk about social support, and I do want to highlight the importance of caregiver support. That is a whole other talk for another day, but I do want to note that a majority of stroke survivors, when they return to the community, will rely on support in some way or another, and often long-term from an informal or a family caregiver. So providing support emotionally and psychologically prepares patients to face various reintegration challenges with greater ease. So as such, the important role caregivers play deserves our attention. And unfortunately, many stroke caregivers may experience financial strain, decreased social contact and activity, and decreased mental and physical health. So similar risk factors as our stroke survivors. But the health of the stroke caregiver directly affects the stroke survivor, essentially as the caregiver is less able to care for themselves, they are less able to provide care and support for their loved one, impacting their survivor's quality of life. And there have found significant correlations between caregivers' well-being and stroke survivors' quality of life and community reintegration. So interventions targeted at reducing caregiver burden may help improve both caregivers and survivors' well-being and quality of life. So it's important to address caregivers' health and quality of life and well-being. Not the focus of today's talk, but it's worth diving into another day. All right, our third construct, providing health education. So one of the strategies that can be helpful, is learning to control what you can to reduce risk where possible. So making lifestyle changes such as diet, exercise, smoking, alcohol use can increase one's sense of control and self-efficacy, moving from a passive or a helpless victim into a more action-oriented mode, which is a much healthier frame of mind psychologically, right? That's all about the empowerment theory. So stress management is another important skill to learn, both because stress is another risk factor, but also because poorly managed stress leads to increase in anxiety, depression, and substance misuse, which could decrease quality of life. And it is important to emphasize that education provided should be in a way that promotes self-management of these various risk factors. So you're not just teaching at your clients, you're providing self-management strategies. That's another talk in itself as well, providing self-management strategies for stroke survivors. But there are many resources available that hold clients accountable for taking control of these risk factors, including keeping a health log for food or alcohol, or a sleep log, using a recipe book catered specifically for that person and to accommodate any comorbidities, medication management tools, ongoing exercises and home exercise programs for both physical health and brain health as well. So construct number 4, increasing self-efficacy, is really highly correlated with building resilience, which is our last one. So Bandura describes self-efficacy as this confidence in one's ability to perform a task or a specific behavior. So a high sense of self-efficacy leads to desired outcomes such as improved health and improved quality of life. So self-efficacy is a situation and task-related behavior-specific concept which can be developed by 4 main sources of influence. So one is mastery experience through successful performance of a task. So that's where you have your mass blocked practice to make sure you've mastered this experience. Vicarious experience, that's where you have your modeling of these behaviors, observing others. Verbal persuasion or encouragement, that's your reinforcement. And the physiological state, being able to interpret physiological signs such as anxiety, stress, and know what to do about them. So in order to develop a healthy sense of self, and self-esteem, there are certain tasks or challenges that need to be addressed. They are tasks that we are all faced with as we grow up and make our way into the world as psychologically healthy and functioning adults. So following a stroke, these may well require different solutions, different ways of thinking about oneself relative to solutions from the past. So again, building on that strengths foundation. So the last one is building resilience. So lastly, we need to help our clients build resilience. Again, this is an ongoing, lifelong endeavor. It doesn't end after you check a box. So stroke survivors may be at risk for low resilience, which was found to correlate with psychological distress and psychosocial maladjustment. So developing interventions to strengthen resilience resilient skills has the potential to improve post-injury psychosocial adjustment. So it is important to note that resilience is not an inherent quality, and these features or behaviors can be taught and reinforced. So I'll put some ideas up here, providing positive life perspective, making meaning out of challenge, maintaining spiritual connectivity, identifying, communicating feelings, life engagement, effective problem solving, hope-filled. So this is again where the empowerment theory ties in nicely when we think about wanting to build upon the client's inherent strengths. There's a lot of emphasis on hope and positivity, shifting to an internal locus of control where the client has control over his, her, or their attitudes, preparations, and effort, and making meaning out of a challenge with a flexible view of success. So the onus shifts to the client, again, making that recovery process more active than passive, but also noting that it is, again, an ongoing process that never ends. It's a lifestyle change that requires frequent reassessment and self-evaluation. So I do want to note this is when I'm working with clients, I emphasize the importance of celebrating little achievements and the significance of short-term goals versus long-term goals, but even just celebrating being able to thread an arm through a shirt is a feat in itself. So I want to encourage everyone to celebrate the little accomplishments since they do all add up. I do want to note a few conclusions from the literature on resilience that states that those who are more resilient have significantly fewer depressive symptoms and report higher quality of life in spite of relatively high levels of pain or fatigue. And additionally, across a 3-year study, stroke survivors with higher resilience demonstrated higher social functioning and less depression. So there are a lot of wonderful health outcomes out of having a high resilience. So in summary, there are these 5 constructs that when put together really can improve our client's quality of life. So using a strengths-based and behavior change approach, we have the power and skills to help our clients improve quality of life post-stroke. Again, these are 5 constructs that have been proven to increase health-related quality of life and do not exist in silo, but rather require thoughtful integration of all 5 into practice. Lastly, interventions that target quality of life needs to be holistic and person-centered and implemented by an interdisciplinary team in order to successfully address the many domains, including health, emotion, self-perception, social engagement, and environmental factors. And I just have a few acknowledgements. I want to thank the ACRM Stroke ISIG, particularly the Health and Wellness Task Force led by Suzanne Burns and Emily Kringle. Patricia Hine, she helped organize this, and then Samir, Chris, Valerie, Abigail, and Alex and I all presented last year on a similar topic. I adapted this presentation slightly for today, but they also have contributed in ways that cannot be seen. So thank you.
Thank you, Dr. Katz. I think we've also had Alex present a couple of months back. And thank you for that very informative presentation. I'd like to open the session now for any comments or questions that our participants may have. And then maybe I can start off with one. So in your experience, Dr. Katz, how are you able to integrate these principles in your work right now in Spalding?
That's a good question. So I really should have noted in the social participation and engagement, the virtual context. So I find peer support to be really useful and beneficial, and the feedback I've gotten from previous patients is outstanding. So we're using peer visitors remotely with the virtual context to help with the social supports. I still encourage, I think family members play a huge role in motivating our clients. So even when I'm working with a client, we've had a no visitor policy, then we could call a family member on FaceTime if we have the technology available to us to help with that motivating factor to engage in activities.
It's actually interesting. The past 3 months have really pushed us all into this need to adopt technology that's always been available and maybe just, I don't know, on the border, questionably acceptable in healthcare, but because it seems like we didn't have a choice, it just made us just go for it. And with very much needed, in a very much needed time. And I think it's actually a viable way of offering support. So we've seen that as well at Cedars.
I think that I love the technology and I think it's been incredibly useful. And I'm just thinking a barrier that I've experienced is the communication,
Correct.
especially having to wear masks.
Yes.
Whether online or virtually, if I'm in a mask and I'm talking to a family member, but I can't take my mask off, or if I'm in with a client in person, our patients get a lot of feedback from our nonverbals, just smiling at them, and I feel the desire to remove my mask just to give them that feedback, the visual feedback, or with communication, the enunciation for those who have trouble. It's been a challenge with COVID.
That's for sure. Anyone else with questions for our speaker? Okay, so this presentation can be viewed later on for the rest of the group. We'll send the link once it's available. But once again, on behalf of Stroke ISIG, thank you very much for all your work. Doing a presentation is part of the work, but a lot of the work is really more behind the scenes, and to be able to summarize that and share that with us really just gives us more energy to keep doing what we're doing in our own little way, whatever it is. Thank you so much, Dr. Katz. Thank you everyone for joining us and taking the time today to sign on, and see you for our next virtual happy hour. Or if not, maybe see you in Atlanta for a conference. Thank you so much, everyone.
Thank you so much for being here and inviting me. Appreciate it.
Bye-bye.
Thank you.
Bye.